mine in particular was a 7-year-old when I was doing that pediatric cancer research. His parents decided to give him heavy doses of vitamin A and carrot juice in hopes that it would cure his cancer. And pediatric cancers, at least the type he had, ALL, have a 90% cure rate. But instead, this child had to die because his parents decided to pump him full of vitamin A instead of, using the standardized cure. When you say you're getting something that's natural, you never know if you're actually getting what's supposed to be in the product. So let's say that the product says it has jojoba oil. Well, it could really have arsenic.
So welcome, Dr. Sloane, onto the podcast today.
I appreciate it.
So I just want to start off with just talking more about your training as a physician, like what made you go into medical school and
Yeah. So, I wasn't exactly sure what I wanted to do. I'm the kind of person that really likes everything. And so I had jumped around through most of the science majors. I had always thought that I wanted to be a teacher. So, at one point I was an aerospace engineer. Another point I was a journalism major. And finally, I realized that I'm not amazing at any one thing, but I'm pretty good at a lot of different things. And I found that medicine allowed me to combine all of those different interests. Once I got into medicine, however, I thought I wanted to do pediatric hematology and oncology, essentially peds cancer, but found that was a little harder to cope with than I thought. And so as a result of that, I really just kept an open mind during my rotations in medical school and was surprised how appealing I found obstetrics and gynecology. In medical school, I was the person that, again, liked everything. So I liked surgery, I liked research, I liked family medicine, I liked psychiatry, and obstetrics and gynecology was really the only field that offered me that variety to continue to do all of those things. I'm in the OR, but not always a surgeon. I'm in the office, but not always in the office. I get to deliver babies, which is completely unique. And I get longitudinal relationships with patients, which I really appreciate.
And for some people who don't know what obstetrics and gynecology is, can you just give a brief overview and definition of this field?
Obstetrics and gynecology is a profession where you are a practitioner of all things women's health. And so, as I was saying before, I really appreciated the variety. And so instead of just being a heart doctor where I focus on the heart or a lung doctor where I focus on the lungs, I am a women's health practitioner. And so I focus on all things women's health. And that ranges from things like, issues with women's reproductive organs and surgical issues with the reproductive organs through, basically preventative medicine. So annual exams, heart, lungs, pelvis, abdomen. We also do women's health regarding pregnancies and high-risk pregnancies and the care and delivery of infants. And so we get kind of this whole systemic approach to the body as opposed to focusing on just one organ system, which, again, I found very appealing.
And did you actually consider some other specialties when you were in medical school?
Yes, yeah, absolutely. As I said before, thinking that I wanted to do hematology and oncology, so essentially cancer for children. And actually all of my research is in cancer for children. I did that for 4 years. But as I realized that was difficult, from an emotional standpoint, I started to shift my gears towards being open-minded. And the 3 professions that I was kind of debating between were psychiatry, family medicine, and obstetrics and gynecology. And so I actually remember a conversation with my, at that point, girlfriend, who is now my wife. And we were sitting in the car outside of her apartment and kind of debating where do we go from here? Do we go into family medicine? Do we go into psychiatry? And I remember heavily emphasizing family medicine, actually. But at the end of our discussion, I had leaned towards OBGYN because I got a little bit of family medicine, but didn't have to only do family medicine. I got a little bit of psychiatry, but didn't have to only do psychiatry. And again, that variety was very appealing to me because I didn't want to have to give up anything.
And now going into actually the aspect of critically evaluating research papers, you had an opportunity to actually, because after you were in your residency, did you actually have an opportunity to perhaps did it encourage you to read more research, published data? And
so, having worked in a research lab for, 6 years, 2 years in college under a Rhodes Scholar and MacArthur Foundation Fellow, Beth Shapiro, and then subsequently as a medical student under Sinija Dovat, who is one of the lead translational research practitioners at my medical school. I learned to critically evaluate research and to publish research, but realized that my real passion was in educating patients and in working directly with patients. And so my emphasis now is more as a one-on-one practitioner with my patients and less emphasis on research.
Did that expose you more into the research field when you were working in MacArthur?
Oh, yes, absolutely. Yeah. Before I had done any of that direct research, I, had read research papers. I had 2 different majors in college and they were really diametrically opposed. So, one was, political science, which was basically a Bachelor of Arts, and the other was actually called pre-medicine, which was essentially a science major where you take science classes for each major. So I took the same physics classes as the physics majors, the same biology classes as the biology majors. And so I was heavily exposed to research at that point, and that really gave me a lot of insight into the strengths as well as the weaknesses of the medical field. That we are still practicing medicine, we're still learning, and that research can always change. This is something that we're seeing a lot with COVID, actually, that, science isn't perfect, that we don't have all the information, and that sometimes the recommendation can change as we learn more over time, which is something that, I learned very early on as a researcher, that sometimes our, pre-held beliefs can change based on the evidence. And so I am very heavily into evidence-based research. I've actually had an article published, or I guess I was interviewed for in the U.S. Health News and Report for basically my emphasis and, really discussion on what is evidence-based research, and that medicine is really moving towards evidence-based research so that we are making sure that we practice the most up-to-date and current medicine for our patients.
And you also won several teaching awards. One of them was the Gold Humanism Honor Society it was actually the Humanism in Medicine Award.
Yes, sir. Yes. So, teaching, as I said, was something that I had really heavily emphasized in college. I was actually the lead tutor for a 40-person tutoring center at Penn State University, where I went to college. And so teaching has always really been a passion of mine. Excuse me. So teaching has always really been a passion of mine. And so I'd actually won several teaching awards just by doing what I do on TikTok and now on Instagram, which is, trying to be straightforward and not beat around the bush. I always kind of say that, medicine is a discussion, not a dictation, or that it's education, not dictation. And so my basic idea there is that patients now have autonomy. My medical school heavily emphasized medical ethics, which is really new in medicine to emphasize ethics. There's kind of this older philosophy in medicine that patients and doctors essentially should be paternalistic, which, is a very outdated philosophy, that practitioners should be parental in nature, should be talking down to their patients and doing what's best for them. And that they shouldn't necessarily or don't have the capability to make their own decisions. And of course, medical ethics now tells us that patients have autonomy, which means that they, have the right to make their own decisions. But of course, in order to do that, they need to be informed. And that's what informed consent is all about. Us educating you so that you can make informed decisions about your own health care. And so, I take that philosophy, and as I approach medicine, I had done that with students. And as a result, they had nominated me for teaching awards at their medical schools. And I had won those awards, both through my residency program as well as through their medical school. But they had also nominated me through their medical school for the Gold Humanism Award after they saw my interaction with patients. And again, this award essentially emphasizes or honors practitioners who practice humanism in medicine, treating the patient like a human, as opposed to, again, kind of dictating how the care should be.
And did you actually, is this award with other physicians, do you get nominated for it, or is it you get selected among your peers that you work with?
Yeah, it's a little bit of both. So it's not something that I applied for or even knew that I was a candidate for, which is true as well for the teaching awards. I got nominated by the medical students who saw me interact with my patients, and then subsequently, other people were nominated, and I, again, subsequently won the award over other people, as, each class. So medical school has 4 years, and the third or fourth year class in that medical school had nominated me, and I, won compared to other people that had also been nominated.
And talking more about informed consent, I think that's quite interesting because not many physicians talk about that. There was a video that struck me. I think you did a reaction to on TikTok. It was another doctor, physician, MD, who put a video out saying that doctors aren't there to solve your problem, but they're there to actually guide you. Your health is actually in your own hands as a patient. They can just give you the treatment options, but you make a decision at the end, and you're responsible for your health. I think the title was "We're not responsible for your health, you are."
Yeah, I'm actually not sure. That's not exactly my philosophy, and I'm not sure that is actually one of my videos, because I actually agree with the other doctor that,
not one of your videos.
Yeah,
it was
sorry
someone
about
else's
that.
video. I think you did a stitch too.
Oh, okay. Yeah. I mean, I don't recall that video in specific, but I agree that, patients are responsible for their own health, but I don't mean it in the way that we shouldn't take responsibility as physicians. And again, I don't recall the specific video, but really, again, my philosophy is that our role as physicians is to be a guide, to be a teacher. So when people come into the office, I see my role as an educator and a communicator. And that's actually what I call myself. If anyone has ever seen the Discovery Channel or the Science Channel, there are people like Michio Kaku and Neil deGrasse Tyson who basically are world-renowned physicists who try to break that information down in a way that people can understand to help people not only understand science, but get interested in STEM and science. And I see my role as doing that in the medical world. I want to take difficult and complicated medical concepts and break them down in such a way that patients can then use that information to educate and advocate for their own healthcare, because not every practitioner gives patients choices, and not every practitioner treats the patient as an autonomous human being, as someone who can make an educated and informed decision based on their own healthcare and their own knowledge of their own bodies and health. So that is always my philosophy, is that, again, medicine is a discussion and not a dictation, and that we are here as educators to help you learn more about yourself and make decisions about yourself that will align with your views on life, not necessarily what I think is best for you.
It also hits me because we see other people from other professions in alternative medicine coming in, and they have this marketing kind of spiel which goes on that we focus on the cause and not the symptoms. Doctors don't focus on the cause, but they treat the symptoms with medications and a whole host of treatments that don't really cure the problem. But that really, also yourself, because we were discussing this outside of the podcast, where you felt infuriated because that's simply not the case, because this is all there is. Like, you train in this as a doctor, you do your MD or DO degree, and then from there you actually do a residency. So whatever specialty you go into, that's it. You're doing everything you can in that specialty. And if someone else is talking about that they have some other treatment options, that sounds a bit dubious, because as a physician, the first thing is integrity and honesty. And if you're learning everything that there is in specialty and you're training in those residencies, which are extremely rigorous, and you're keeping up to date within the field, what more else is there in the world of that specialty that you focus on?
Yeah, I don't think that, I believe in that to an extent. I don't think that I'm so close-minded as to think that people that are MDs or DOs know everything. As we always say, we're practicing medicine, so there's always more to learn, and we are lifelong learners. And I definitely think, as we had talked about prior to the podcast on a different occasion, that there are certain alternative medicine treatments that work. I actually have a skin condition, and I've tried many different medicines and found that essential oils work better than really anything else. I think the point that I always try to get across is that if something like an essential oil is working for you, then there must be some medicine in it that is working for that disease. So when we say things are natural or that things don't have side effects, that just isn't true. I mean, everything has a side effect. And just because we don't know what in that essential oil is working for that condition doesn't mean that there isn't something active in that essential oil that essentially is a medicine. You know, anything that cures a medical condition is a medicine. A lot of medicines were actually derived from nature. Things like the narcotics that we now use for pain are derived from the poppy seed. And so, you know, people could theoretically take lots of poppy seeds and get pain control and say that it's natural. But at the end of the day, there is an active ingredient, something essentially related to morphine that is giving you that benefit. And so to say that that isn't a medication or that natural things are better than medications, I think is wrong. I think that there is a world where we can all work together, and that it's important that as practitioners, we acknowledge that these medicines that are, you know, Eastern medicine in nature can actually be helpful, just like the people who practice Eastern medicine shouldn't be so quick to negate evidence-based medicine. And when I say evidence-based medicine, again, I don't mean that our medicine is better than their medicine. The difference there is that, you know, when you say you're getting something, let's say from a compounding pharmacy or something that's natural, you never know if you're actually getting what's supposed to be in the product. So let's say that the product says it has jojoba oil. Well, it could really have arsenic. There is no FDA, at least in the United States, that can look at that product and say that the concentration or the dose that they say is in there is actually in there, or that the product standardized or regulated medicine where we can say what's inside that medicine is exactly what we tell you that it is. And so, you know, in the end, again, I think that we can work together. I think we have a lot to learn from Eastern medicine in the sense that we should be working together. We know that Eastern medicine sometimes works. There is evidence to support things like acupuncture actually works. And again, essential oils work for me, but we don't know that stuff works. So we should be doing research to say why that stuff works. And on the other hand, people who believe in that stuff should really acknowledge that there is an active ingredient in there, that active ingredient presumably can have side effects at higher or prolonged exposure. And that really we're all talking about the same thing. We just have to acknowledge that there is no standardization for that stuff. And so we really should be doing evidence to figure out why it works and then integrating it into this standardized and evidence-based system so that we know that it's safe and we know which side effects it may have.
And I've actually come across patients, not necessarily patients, but also people like on my TikTok channel asking me about, I'll put videos on the causes of perhaps neuropathy, and they'll ask me about, so what's the solution? And it's difficult because you can't give medical advice online. It's almost illegal and it's just not professional. But even then, there is no one treatment that fits all. But one treatment that came across my mind was a supplement called alpha liponic. So I was reading some papers on that, but the evidence, I'm not going so much into this as a topic, but I'm just giving an example. It was kind of anecdotal. So there's research done, but it's not strong enough. But it suggests that some people who've actually been using it have reported improvements in their neuropathy. But here's the thing, I delved more into it. Obviously, it's not FDA approved, but the FDA actually published some guidelines on it and said that they actually found there was actually some toxins found in some of the suppliers of this supplement. So that's kind of scary because, again, it's not regulated. So therefore, they don't need to report what their substances are directly to anyone. They can do anything they want. So that's an interesting aspect where you really need, everything should be FDA regulated, even if it's turmeric powder or a turmeric supplement, because even those can, in high doses, have side effects or interact with other medications.
And that's the moral of the story here is that, you know, those things theoretically can work, but you want to make sure what you're taking is really what they say it is. And of course, without having FDA approval or any type of oversight, we really don't know what the side effects are. You know, part of the FDA approval process, as we're all learning again with the COVID vaccine, is at first you have to test the medication to see what the side effects are. And you actually go higher than the standardized dose so that you can see at which dose those side effects occur, what those side effects are. And then you do post-market surveillance where once the medication is released on the market, you have people report back which kind of side effects they have so that we actually can learn, you know, the full realm of potential side effects once a drug is out on the market. So it's really important that we know those things so that we can help people figure out which medications are going to interact with other medications, which medications may worsen some of your comorbid or chronic medical conditions. And of course, you know, make sure that the medication that you're taking is is good so that you don't end up having side effects or toxins that you weren't intending on taking.
And what's more interesting, some of these supplements are not really needed, because I found that, for instance, the alpha liponic was actually available in vegetables such as broccoli, tomatoes, as an example. So if you're actually getting it naturally from foods, and you don't actually necessarily need the supplements, but then some people argue you're not getting enough from the foods itself. So there isn't a linear kind of explanation or system that works. A physician many years ago told me, for instance, if you have vitamin D deficiency, after the blood test, obviously, if it's quite low, you can actually just take supplements just to top up with it, but then come back, have blood tests again. If it comes back to normal, that means you don't really need to necessarily continue taking it, because then you could have an overdose on that.
Yeah, I mean, absolutely. There is a such thing as too many vitamins, hypervitaminosis, and things like vitamin A have even been shown to cause birth defects. But if we didn't do any research on vitamin A because it's natural, then we wouldn't have known that. And so it's really, really important, again, that we know what the maximum dose should be, and the purity of that substance. And that's where, organizations like the USP are starting to come out that are doing that for supplements, but there's still a long way to go. And I think that, again, I support holistic medical practitioners to an extent, but I think it's important that they're honest that, there is some sort of active ingredient in the things that they're using, and that, perhaps we don't have all of the evidence to know exactly what the side effects and purity of these substances are, because they're not regulated by the FDA. So, I'm not necessarily anti-Eastern or holistic medicine, but I do find that I have a lot of patients who seek both. And I oftentimes will make sure that they understand that there are potential downsides to these unregulated medications.
And obviously one of them is drug interactions. So long as you know that they're taking a supplement or something that's been provided, prescribed from a holistic practitioner in alternative medicine, it's best that you know what they're taking, so you you can rule out it's not interacting with any of the drugs that you're prescribing them or the treatments that you're providing them. But then the other end of the hook is actually a person who chooses not to, if they've got a chronic disease or condition, and they choose not to continue with conventional medicine treatments, that could also pose a danger, because then the progression of that disease could go and linger on. Whereas, evidence-based, even though some causes, we don't know what the exact cause is, but we know some treatments have been responding quite well in a 60 to 70% rate. Obviously, it doesn't cure it, because there's no cure for some diseases yet. But we know by taking this medication, for instance, like rheumatoid arthritis, that we can slow down progression. And that itself is where we're heading towards. So I just find it kind of interesting, because it could also prevent you from seeking the conventional therapy, which at the long term could actually put yourself into greater risk of that condition.
Yeah, I mean, absolutely. That connects back to everything that we're saying, that essentially, although a lot of these medications do provide some benefits, and certainly can be part of a whole body approach, it is, I'm always reticent to say to completely negate standardized evidence-based medicine for false promises that a lot of these people will offer. A lot of these people will say, oh, not only are there no side effects, but this thing works for, excuse me. Not only that there are no side effects, but that this thing works for cancer and rheumatoid arthritis and ectopic pregnancy and this and that. And, you have to be honest with yourself. There's just no such thing as a catch-all cure. I mean, that's why we say, we have that expression that this person, sells snake oil. And that's because someone actually went out and used to sell snake oil as a catch-all. And then we subsequently learned that there were really no benefits from that. And so, you have to be cautious of people who are snake oil salesmen, people who say this has no side effects and will help you with every medical condition you have. There's just no such thing. There is an active ingredient in that, and presumably that active ingredient works for some things and doesn't work for others. And so, you never want to negate a cure that has been proven to help for, doesn't necessarily help. A few patients that stand out in their mind, mine in particular was a 7-year-old when I was doing that pediatric cancer research, who, his parents decided to give him heavy doses of vitamin A and carrot juice in hopes that it would cure his cancer. And pediatric cancers, at least the type he had, ALL, have a 90% cure rate. But instead, this child had to die because his parents decided to pump him full of vitamin A instead of, using the standardized cure. And so, there are these tales of caution. Again, that doesn't mean that you can't seek alternative therapy, and certain alternative therapies even are evidence-based and have proof that some of them work. But you have to be cautious for the person who's personally selling something. The only money that I make is for my time to educate you. I'm not invested in any pharmaceutical company that makes the pill that I give you. That is always a conflict of interest. So anyone who's trying to sell you something personally, you really have to be cautious and wonder, do they have something to gain from this? And are they biased in what they're telling you because there is a financial benefit?
In the US, we have pharmaceutical companies that influence some physicians prescribing the medications. And I think that is a conflict of interest. And if a physician is going to prescribe a patient some medication to someone, they need to be honest and tell them, like, I am involved in this trial. Or obviously that's it's something that I've read about, but talking to physicians such as yourself, I've rarely seen that in my personal experience. I mean, does it happen quite often, or is it quite rare that some physicians actually?
Yeah. So, we have stories, that throughout medical history where, for example, people may recommend more surgeries than usual because they own a stake in the surgery center. So now they get paid twice, as the surgeon as well as the owner of the surgery center, or someone who owns or is part of a pharmaceutical company. Look at Dr. Oz, he sells all of these supplements and gets paid by those pharmaceutical companies. So he has a stake in whether the company does well or not. And so, it's a reason to push something that may not be evidence-based. And same with Dr. Phil. Whereas, I think most people in, academic medicine, usually when I get a lecture, they'll say, these are my conflicts of interest. These are the 4 companies I work for. Every once in a while, I'm a consultant for a birth control company. Now, I do get paid a small amount, I think it was $300 to give my opinion as an OBGYN, but I don't push their medicines anymore than I would other medicines. And when I do talk about their medicines, I make sure that my patients know, hey, by the way, I'm a paid consultant for this company, but I want you to know these are the benefits and the risks of that medication, and be aware that I'm a consultant for that company on rare occasion. And it wasn't even for the medicine that I was talking about. It was because they wanted to look for new medicines and wanted my opinion on what I thought patients would be interested in. But again, you have to be forthcoming about that. I think a lot of the people who really make a lot of money on these things, like, Dr. Phil and Dr. Oz, they aren't that forthcoming about that. And that's that snake oil salesman kind of tactic where they're selling you things that maybe aren't so evidence-based because there is a financial goal at the end of the day. And so we don't just see that in the holistic world. We see that in the standardized medical world too. And so it's really important to know, you can look that stuff up on the internet, how much money did your physician get paid and what companies paid them. But, they should also be straightforward with that, and you should be willing to ask that, and they should have an open conversation with you about that.
Obviously, it's quite controversial with Dr. Oz. I didn't know so much about Dr. Phil. I thought he was a non-MD doctor. I thought he was a psychologist.
He is, but he still, basically puts his name behind products that aren't necessarily proven because he has a financial incentive.
Wow, so that's quite interesting. I'm guessing he's probably got a PhD or some other doctorate in psychology, but yet portrays himself as a medical doctor with products and other products that he sells and pushes. So that's quite.
Same
strange.
with Dr. Oz. He went to some of the best schools in the country and really is a church and have been found to not be successful. But still, he gets financial incentive for pushing those products. And, if you watch some of his ads, it'll even say, that it's sponsored, or I'll hear things with Dr. Phil where he says, he integrates it almost as if he's having a conversation, but it ends up being a commercial for something that he's trying to sell. And of course is incentivized to sell those things because of the financial implications.
Yeah. I'm missing a lot of that now with a lot of medical influencers coming online. There's a whole host of people coming on. And I've seen some people who actually sell supplements. And it is kind of controversial too. But then I've also seen some people who don't go into that, medical influencers who don't sell anything because they don't want to, because they know it's like a conflict of interest within the medical profession.
Yeah, one of the first people that reached out to me once I started becoming popular on TikTok was like a Norwegian or Swedish vitamin company. Would I be interested in getting paid to promote their product? I had never even heard of their product. I didn't know any of the research of their product. But of course, had I not had medical standards, I could certainly accept a cash allowance in order to promote this product that I really didn't know anything about or believe in. And so I make it very straightforward. When somebody gives me something for free or pays me to promote something, I'm going to say that they gave me this for free or that they paid me to promote this. And I will never promote a medical product that I don't believe in and that I don't believe there is evidence for. And that's one of the issues that I think the medical community has with people like Dr. Oz, is that essentially he has sold out his medical education to the highest bidder. And, this having nothing to do with his politics, but that, does make you worry. What is he willing to say? Is he willing to say anything at a cost?
Yeah, I knew of another medical influencer who actually made a video about pre and probiotic supplements, how ineffective they are, that they may be beneficial for two things. One was diarrhea and I think one was IBS. But a company then approached him and they were paying him a lot of money, 3 times his salary as a retainer of what he earns a month. But he declined them. It was tempting, but he actually said, I can't. I made a video saying that you don't need them. Now I've got some opportunity to sell them. Like, I can't do that. So it's interesting that it's tempting when you have a lot of money, like a big jump of change from a company that are actually trying to approach you to sell their product. But at the same time, you've got to be kind of honest to yourself, because it is actually controversial. And I mean, it'd be great if the product was great, a good product, which had a lot of evidence. And then you could go behind it and say, okay, from an honest point of view.
Yeah, absolutely. Again, a lot of, new doctors, we're in tons of debt. We're working hundreds of hours a week. We barely see our families. Sometimes my son tries to feed the phone when I'm FaceTiming him at night from the hospital call room. And so, you are incentivized, or, there is that appeal of taking that big paycheck and having a good quality of life. And a lot of people do end up doing that, and I understand it. It is appealing to essentially win the lotto and have a better quality of life. And all you have to do is sell out your morals. But with that being said, a lot of us find that that's not appropriate. And, if you are going to do that, you should be straightforward that you're doing that.
So I want to talk more about your field. One of your interests is pre-eclampsia, which is a complication of pregnancy. Do you want to talk more about what your findings have been and also the research on that current?
Yeah, so pre-eclampsia has definitely changed over several years, and again, as we said earlier in the podcast, medicine is always changing. That's why we're lifelong learners. I think a lot of people have lost confidence in the medical system recently because they see that medicine keeps changing, and so they assume that we don't know what we're talking about. But at the end of the day, the basic idea here is that we have to go off the research. And at least in our minds, it's better to go off what the current research says than to just take a guess. Now, yes, that research may change, but I think it's a good thing that we change as that research changes. That way you're always getting the most up-to-date medicine. And sometimes that up-to-date medicine will conflict with what we previously told you. That doesn't mean you should lose confidence in us. If anything, you should support the fact that we're willing to continually be open-minded about the idea that our culture is changing, our eating habits are changing, Our exposure to certain chemicals and things are changing. And as a result, sometimes recommendations will change. Cave women, when they delivered babies, presumably they didn't have as much access to food as we do. And as a result, they're not going to have larger babies and higher risks of diabetes and pre-eclampsia. So you have to understand that medicine can't be a one size fits all, and that medicine will change over time. That being said, pre-eclampsia is not really the disease. Eclampsia is the disease, and eclampsia is essentially a seizure. Pre-eclampsia is a pre-disease. It was a set of risk factors that we could notice that helped us catch eclampsia early so that we could prevent people from having a seizure. And that risk factor essentially is that if you have high blood pressure or lab abnormalities, that would be a sign that you might be someone who's at risk for subsequently developing eclampsia. Nowadays, on the other hand, we're so good at capturing people in the pre-eclampsia phase. A lot of patients don't even know eclampsia exists unless they were fans of, Downton Abbey. And so now, again, being so good at capturing pre-eclampsia, we're starting to try to capture people in the pre-eclampsia phase. What are those risk factors that people develop earlier than pre-eclampsia that tell us that they may be subsequently going on to or developing pre-eclampsia? And so that pre-eclampsia is actually known as gestational hypertension or mild pre-eclampsia or pre-eclampsia without severe features. Lots of different names for the same thing, which essentially is a set of signs and symptoms that tell us that, you don't really have a disease, but you have a risk for developing that disease. And if we can catch it early enough, we can prevent it from progressing.
And what are some of those things people can look out for to prevent eclampsia? Obviously, known as pre-eclampsia before it happens.
Yeah. So again, eclampsia is a seizure. Pre-eclampsia is either lab abnormalities that show us that your internal organs are not happy with your blood pressure. So kidney damage, liver damage, breakdown of blood in your body, leading to lower blood and lower, blood clotting factors like platelets. And now in the elevated blood pressure above 160 systolic, which is the top number, or 110 diastolic, which is the bottom number. And not just on occasion, but something that's either persistent or has shown that there's a pattern, that it keeps coming back, versus, this pre-eclampsia phase, again, gestational hypertension or pre-eclampsia without severe features, which is just a lower threshold. No lab abnormalities and blood pressures with 140 instead of 160 or 90 instead of 110. Again, just a little above normal, but not quite at that high enough level. And again, that tells us that, you're higher than normal, but you haven't gotten to that bad part yet. So maybe we still have some time to intervene, get you delivered before it's too late. And so people with pre-eclampsia get delivered at 34 weeks. People with eclampsia get delivered happens, and people with pre-eclampsia get delivered at 30. Sorry, I've been up all night helping people deliver their babies. I'm just a little dry. But the basic idea here is that we're trying to intervene at the time that it happens and balance those benefits and risks. So if you have a riskier condition like pre-eclampsia, it actually benefits us to deliver you at an earlier gestational age, 34 weeks, because at that point, the risk to the mom outweighs the risk to the baby. Whereas if you only have pre-eclampsia, we're not going to deliver you at that same time frame because, then the risk to the baby outweigh the risk to the mom. But if you're 37 weeks, you're full term, now it doesn't make sense to keep you pregnant any longer because we don't want the risk to the mom to continue to go up, knowing that the baby is full term and will do just fine. So these guidelines, again, are always continually changing, but the basic idea here is that we're trying to look for risk factors that will help us identify these symptoms that pre-exist the disease. We call that the prodrome in medicine, these symptoms that are prodromal that tell us a disease is coming but hasn't come yet.
And what are some of these complications, if we can highlight that again, pre-eclampsia?
Yeah, so the complications of pre-eclampsia essentially are that you can go on to develop eclampsia, but also that as your blood pressure gets higher, that pulsing, that strength of that pressure of the blood flowing through your system can actually damage, transiently, not something that's permanent, but can damage your internal organs, leading to liver damage or kidney damage, blood vessel damage that can destroy blood cells and cause anemia or higher levels of bleeding. And we want to try to avoid that because eventually those things can actually lead to harm for the mother or lead to harm for the baby. And so if we can capture it at an early enough stage and, prevent it from getting any worse by delivering your baby, we can then help the baby not progress to a point where the baby can be harmed, and also help the mother not progress to a point where maternal health can be harmed.
And what are some measures people can take to avoid the pre-eclampsia from developing?
Yeah. So, sadly, a lot of this is genetic. Separately, we don't actually know the cause of preeclampsia. We know it has something to do with the placenta, because the placenta is a huge bed of blood vessels. And of course, your entire circulatory system is one continuous loop. So if any point of that system gets constricted, or, blood flow is not quite as good, the rest of the system has a backup and the blood pressure will go up. So we know it has something to do with the placenta. We know it has something to do with the blood vessels. But with all of that being said, we don't know the exact cause, or have any tests to really identify it earlier yet, although certain things are being researched. And so as a result, there's not a lot that parents can do to help avoid that. The biggest thing is, of course, to try to exercise and eat a healthy diet, and, avoid high salt objects, not smoke cigarettes, do all the things that lower blood pressure outside of pregnancy. And those are called modifiable risk factors, essentially risk factors that you can modify, but there are a lot of non-modifiable risk factors too. And so it's important to get consistent prenatal care so that we can, as practitioners, try to identify those issues before they progress to a point where they can be harmful to the mother or the baby. And
also, just to highlight, because you actually sent me this paper to read, and it was interesting because around the world, compared to the US, the rates are much lower, and it's been increasing a lot in the US itself. It's since the last 10 years, in fact.
Yeah, and part of that is diagnosis. People might use different guidelines in different countries. And so, what we might call preeclampsia here is not called preeclampsia somewhere else. But also part of it, again, might be the environment. We live in a different location than other people. So what are we exposed to? Different levels of smog and poisons and gliadin and gluten in our bread versus things that aren't in the bread in other countries, and the water in other countries. And of course, also the diet in our population. I think that I haven't, again, I'm an OBGYN, but I think the last statistic I had heard was that, at least 1/3 of the United States population has diabetes. And more than that, we're obese. And so all of those things are, again, modifiable risk factors that other countries might not necessarily have. But again, not knowing the cause of preeclampsia, I'm sure there are other things that they might be exposed to in our country that other countries don't have. And so at least what we can do is try to modify the risk factors we can, making sure that people are healthy, come into pregnancy at a healthy, eat a healthy diet, avoid things like smoking cigarettes, etc.
There's so many factors. In fact, I was actually reading a paper on that in California and the US about air pollution. There's actually some chemicals in the air which are quite high because they develop in the soil. I can't remember the exact name, what element it was, but one of them is formaldehyde. It's actually in furniture. So if you have a high level of that, again, we don't know what the effects are on people because it's just difficult to measure. I was talking to a relative about it, and so you can buy this meter on Amazon, and you can actually detect, it tells you the amount of formaldehyde and other substance elements which are toxic in your house. And there's things you can do just to increase ventilation. So it's right, because you mentioned about water, so many other external environmental factors which you have very minimal control over. So they could also have an impact on a lot of health aspects and development of diseases. Do you have anything that you found quite interesting that you've seen within your patients?
Yeah, nothing that's different than the rest of the, U.S. population. And that's why it's important, for doctors to continue to read journal articles and continue to stay up to date. And there's actually a system in the United States called the Maintenance of Certification System, where essentially we are forced, rightfully so, to continually read research papers and journal articles and take quizzes on them so that we can continue to stay up to date on the most current research as our environment and our system continues to change.
So we've got actually, there's treatments such as IVF, which there was a Netflix TV show which went quite popular, where there was a documented woman, I think she was in the 70s, who used IVF to get pregnant. But more or less, the question was about what can women do? Because obviously after the age of 35, your chances start diminishing. What things or measures, is there anything out there for women who want to increase the chance of pregnancy after the age of 35? If you can just talk about your view on that and your take and what you found in your practice.
Yeah, I think the first thing to understand is that 35 is kind of a made up number. It's not like a finger snaps at 35 and all of a sudden people have trouble getting pregnant. As you age, the risk gets harder and harder and harder. If we look at like the Egyptians or presumably cave women, they were having babies at 12, 13, 14, 15, 16. So our bodies are really set up to have children at a younger age. And, we can see that biologically. When you are a fetus inside your mother, you actually have more eggs before birth than you have at birth. And then those eggs at birth are the only eggs you're ever going to have. And they diminish over time from the second you're born until you go through menopause. And so with that being said, a 25-year-old has a higher risk of having a genetic abnormality or a stillbirth than a 20-year-old, and a 30-year-old than a 25-year-old. And so that number continues to go down until a point where it does become prohibitively difficult to get pregnant on your own. And that age seems to be about 40. The reason that we had chosen 35 is that 35, in the 80s, the test that we used to determine whether the baby had a genetic defect, we wanted to make sure that the benefits and the risks balanced out. And so the risks of that test were equivalent at 35 to the risk of actually finding a disease. And so that's the age where it made sense for people to then go get that test. But nowadays, that test is actually still around, but much better. That's amniocentesis. And we have better tests to look for genetic diseases. So really 40 is the age where, there's diminishing returns. Now, of course, if you use a donor egg, where the egg is not as old as you are, theoretically, you could have a 70-year-old who gets pregnant. And really the only issues there are whether her body can support that pregnancy now that she has 70-year-old blood vessels and, 70-year-old heart, et cetera. But if you're looking to use your own egg, then really you just have to be aware that, there's really only so much that medical science can do, and that if you do think that you're going to want to have a child after 40, as we, start to push childbearing back, as people, start to go into the professional world more and more, that it may be helpful if you have the opportunity and the finances to freeze your eggs at a younger age so that those eggs don't age. What happens with the eggs, to get into a little bit of the science, is that the egg, as does the sperm, has part of mom's DNA and part of dad's DNA. And so the sperm is really just half. It's either mom or dad's DNA packed to the sperm. Of course, it's really a mixture of both. But the egg actually is all of the DNA. It hasn't split yet. So that egg only splits when it goes to ovulate. And so that splitting process, the machinery that breaks up the DNA and gives a piece to the baby, that machinery ages with the mom. And so at 35, that machinery is now 35 years old. And that splitting process, instead of being 50-50, sometimes can be 40-70, which means that baby that then gets created can have too little DNA or too much DNA, which is often the cause of miscarriages. And so we do anything, it'll fix that machinery. We need to get those eggs out, have them split with good machinery at a younger age, and then freeze those eggs once that split has occurred, so that then you can use that egg at any time with a good split versus having that uneven split that might happen at an older age.
But what about someone who's listening to this and they're probably 35 or 36 and they haven't done that yet? Is there anything that it's just, you can only focus on where you're at now, and is there anything that they can do at a later age?
Yeah, I mean, again, if they have the finances or the capability, they could freeze their eggs now. At least their eggs are going to be 35 instead of 40. They could get an egg donor so that they can get a younger egg. Or, if they have a partner and they're ready for childbearing, they could start trying now. I think the idea here is that, again, back to everything that, I believe in, this is all about education. And so women should be aware that, there are diminishing returns at age 40, and be aware that, they theoretically should either start trying sooner if they have that ability or do something to protect their eggs so that they have the ability to have successful pregnancies later. If they don't have those abilities, then, there is that possibility that they may need an egg donor, or could try to spontaneously conceive or try to, do preconception genetic testing to make sure the eggs they do have are genetically stable. But there is going to be some women out there that just won't have the ability to get pregnant. And so, we're trying to catch those people as early as possible to protect their ability to get pregnant if that's what they want.
So these women who perhaps don't have the ability to get pregnant, is that instilled from day one, even at a young age, that they weren't able to become pregnant, or did it develop over time?
So, there are certain diseases that people can be born with or acquire that make it more difficult to get pregnant. But what we're talking about here with, baseline infertility, or I should say fertility and declining fertility over time, is really just a virtue of our genetics. It's something that happens to all women. And, even in men, we're starting to learn that the sperm is not as good of a quality as men age as well, and certainly increases the risk for certain genetic diseases. But as a women's health practitioner, we are learning that this is just a virtue or, on the basis of women's genetics. And so this isn't necessarily a disease. It's just something that happens to us as we age.
So it's just like you mentioned, just to highlight again, if you can afford to get your eggs frozen, that's a good option, but it costs a lot. I'm not sure if some insurance covers it, health insurance plans. I heard from a friend that she worked for a company and it actually covered it. So I suppose it varies from person to person, but that's probably the only option that you have in terms of to freeze it so you can protect it, what the quality of it now as compared to as you age, it'll start diminishing.
Yeah, that's correct. A lot of insurance will not cover freezing, but some insurances will. And so it's certainly worth exploring, especially if this is of interest to you.
And are there any there's so many claims on online, in terms of supplements, prenatal. I think prenatal supplements are the only thing that is evidential that works because it has folic acid and other essential vitamins, but I don't think there's anything else out there that actually can increase your chances. It's just the DNA within yourself.
Yeah, it's the same thing that happens with everything else in our body. Cancer gets higher risk as you age. Diseases get higher risk as you age. DNA starts to break down as you age. This is just our biology. And maybe one day we'll have the science to fight biology or repair biology. But in the meantime, since we don't have that technology, it's just about being aware that that technology does not exist and making plans for the goals that you have in your life.
Yes, because one of the things that I've noticed, there's a commonality in terms of all the diseases. It goes back to the same things in terms of recommendation, obviously diet or eating healthy food, reducing saturated fats, processed foods, working out. It all goes, and the risk factors are essentially almost the same in modern medicine in terms of like if you sedentary lifestyle, smoking. The list goes on and on.
Yes. There's certainly things we can do to slow the process down by having a healthy lifestyle and avoiding processed foods and, damaging our body through things like smoking and alcohol. But the process is going to happen no matter what. We are mortal, and we have to understand that that process exists and that it's going to be slightly different for each person based on their own genetic histories and their own exposures and the environment around them. And they have to make plans to make sure that they can get out of life what they want to based on the inevitability of all of this.
Yeah, and I was listening to it was on a Lewis Howes show. I can't remember the person's name, but he's a famous physician. He's got like a podcast show, and he's got like a clinic he runs. And he mentioned that we can reduce cancer. It's curable. I think he mentioned like 90% or 70% by reducing certain foods and eating more foods which have antioxidants in them. But again, it goes back to nothing's changed in terms of the research from the last 20 years. Everything's essentially the same. Statistics are just a number. And I don't know where people quote statistics, but it's not true necessarily. It just goes back to the foundation so that, you can only reduce these factors, but there's no essential cure that we know evidentially.
Yeah, absolutely. It's back to the snake oil salesman. There are a lot of promises out there, but the technology just doesn't exist. And if you believe in those promises, I think people sometimes are grasping for straws because they want what doesn't exist. And that's why it's so dangerous sometimes. You really have to pick and choose. I always say you should shop around for a doctor. Same thing for your holistic practitioner. There are good holistic practitioners out there. Even some like, I forget his name, the holistic OBGYN, but, we have a few scuffles on Facebook, but at the end of the day, this is an MD who decided to go into holistics. And at least from some of the things I've seen, although I don't agree with everything that he says because, we're on different sides of a spectrum, but he doesn't completely negate standardized medicine for holistic medicine. And I think that that's the route that we should go in the future, is that we need to find some middle ground to understand that, you don't want to accept false promises, but that, there is also a balance to understand that holistic medicine does work in some context, as does standardized medicine.
That's exactly the kind of aspect of medicine is heading towards, because there are a lot of physicians who are medically qualified, but I'm also looking into the function aspects of medicine too. But one thing that blew my mind was I was doing a podcast with another physician, and he said if you go to 3 alternative medicine doctors, by the way, he supported functional medicine because he practices some of it, and he just said they'll give you 3 different answers. So go to 3 different alternative medical practitioners, and they'll perhaps give you 3 different treatment option plans. So because there's no consistency within that sort of field.
Yeah, that's exactly right. And so it's just important to know that they can't give you guarantees. No one can give you guarantees. And, it's good to have options, but that's where the research comes into play. Which option is best for you? How do we trust these options? What are the outcomes that we expect from said options?
And just to finish up with, I think sometimes it's just, I think there's so much pressure on patients who have conditions such as cardiovascular disease. And I remember talking to you about a colleague that I had who he had a mini stroke and then eventually required a heart bypass as a sort of safety precaution measure. But the thing is, he was quite healthy. He used to actually cycle every few days a week for a couple of years. Obviously, he was in his 50s now. Obviously, his dad had cardiovascular disease and passed away from it. But he inherited that from his father. So sometimes you just you're just unlucky and you inherited some genes that increase the risk of developing disease. So sometimes I feel it's not your fault, because even though you can have a healthy lifestyle and take all those measures, you can just reduce the risk. It's still there. And I think there's so much pressure on people who think they need to do something when they're already doing enough. And it's okay to be where you are.
Yeah, in the end of the day, you can't run away from your own mortality. And so as much as none of us like it, we have to live our lives. We have to accept that, there are those modifiable versus non-modifiable risk factors, and do our best to address what we can, but know that, life and DNA catch up with you. And so in the meantime, we have to do the best that we can.
Especially if you've got a familial history of type 2 diabetes. I mean, there's a chance that you might develop it, even though you can do as much as you can to reduce the risk. You can perhaps slow down progression or prevent it from an early age. But I've seen in some cases where patients who've reported to have healthy lifestyles still developed it later on, which is still a pretty good outcome, because they actually spent the early years of their life actually preventing it. So they've had a good lifestyle, a good quality of life, until they've perhaps hit late 40s, 50s, where then like you mentioned, life catches up with you. Perhaps it's your DNA and other genetic aspects that you can't really control. You can just reduce it, but it's still there.
Absolutely.
Well, thank you for coming on the show, Dr. Sloane. I really appreciate your time. Where can people find you?
Yeah, thank you again for having me, and I really appreciate it. We got into a little bit more of politics, but I also, I'm always, like I said, here mostly for education. The education is evidence-based, but the politics are my own. And so, with that being said, if you're interested in more, evidence-based education for advocacy and patient autonomy, you can find me on my TikTok, which is at Dr. Sloane1, or on my Instagram, Justin Sloane MD. It's actually Justin_Sloane_MD.
So yeah, thank you so much. And it'd be a pleasure to perhaps have another podcast with you in the future.
Well, thanks again.